Okay. Just a few important facts about pregnant people in the workplace, colleagues. Number one, it is a privilege to have somebody pregnant and giving you their service. The reason being, this is a very important period of their lives for her and her family. And taking such risks in your workplace or where you are hired as an occupational health and safety professional gives you the privilege to look after them during this important time. You need to remember that not every pregnancy is normal. There may be some complications, and you need to identify those as soon as possible. Again, this can be a very emotional journey, and you still need to provide support for those emotional issues that we normally encounter in the workplace. Privacy is very important, colleagues. Remember, we treat pregnancy like any other medical condition. We don't share with anybody, and ethics apply. Risks exist. By a mere fact of being in the workplace means there is a risk, either controlled or uncontrolled. The risk exists, and we need to identify these risks and manage them. An interesting fact is that 85% of the pregnancy period is spent at work most of the time in normal pregnancies. It may happen that they go on maternity leave earlier, but 85% of the pregnancy is usually spent at work. And believe it or not, colleagues, you are also responsible for that baby. And hence the concept of occupational health for unborn workers, because that baby is still in the place of work and hazards still matter to her or him as much as they do matter to their mother. But why do pregnant women work? First of all, colleagues, we need to anticipate that if we hire people in their childbearing age, they are going to be bound to be pregnant during the occupational period, and we are going to deal with those pregnancies. Secondly, as we know, South African labor laws allow for pregnancy people to participate in work activities and should not be discriminated. And another fact is they need to earn a living just like everybody else. And our role here is to make sure we achieve the balance to the benefit of both the workplace and the employee and the baby. So most pregnancies will start with the diagnosis, and you need to realize that some of these pregnancies may be unplanned. A patient could be in for a normal routine medical assessment, and then you realize she's pregnant. And then there's another interesting issue of failure to disclose for either traditional or religious beliefs. In African culture, colleagues, there are certain people who will not disclose their pregnancies until a certain point in time. And unfortunately, that only presents problems for us because we delay in accommodating them, and you can't do much if you don't know. And when you see this employee, it's important to examine them and establish all the risks. It's important to make sure that they're attending the antenatal visits. Most of the workers will not be attending these visits for the same reason I've explained. Some of them will only wait until they're about 6 or 7 months pregnant, and that on its own is a hazard. And then we do have common conditions that they still present with, like any normal human being, chest infections, UTIs. Please make sure you do this as much ethically as possible. Do not supersede or take over the management of the pregnancy, because we are not pregnancy specialists. You treat basic stuff you can treat, but never deny an employee the opportunity to be referred to an appropriate person who will help them. Then, do we do medical surveillance during pregnancy? Yes, we do. It may be indicated subject to the occupational risk exposure profile. Sometimes it may be random, it may be return to work medical, but medical assessments still need to be done. And the state of their fitness may change also. If she was fit before she fell pregnant, she might no longer be fit after she has fallen pregnant, and we need to take that into account. And other opportunities present themselves during pregnancy. Some people will disappear and then you'll only see them once they are pregnant. You still have the responsibility to perform that medical surveillance. The risk assessment is mostly based on the occupational health triad between the worker, the work, and the workplace. Remember, colleagues, the interaction of these three factors lead to risk, and risk is what we need to manage. And then again, during the first visit or the first few visits, there may be immediate changes that need to be considered and managed. And then you also need to look at ergonomics. Ergonomics are also important. You don't want that pregnant person to be carrying heavy objects, to be pushing, to be standing on their feet for a long time. And then accommodating them. It's important to learn and get used to the idea that at some point, these ladies need to be reasonably accommodated. So you won't be able to do that if you don't do your regular follow-ups. So it's important that you see them regularly. In my clinics, I normally see them every 6 weeks without complications, and obviously more frequently if they have complications. And according to SASOM regulations, around 20-21 weeks, if there are no complications and the work is not too strenuous, they may need to be accommodated. Remember, sometimes their legs swell up, sometimes the time is bigger than it should be. So you always have to consider all these conditions, and you won't be able to if you do not know the patient or if you haven't been checking this patient. Remember, there are external healthcare providers that treat these patients also. You also need to know what they are up to. You also need to understand what their plan is so that you don't contradict them. And sometimes you don't overdose patients with certain medications that they have been given. And please be prepared to manage serious complications and always remember to refer them. In terms of managing complicated pregnancies, our approach in the workplace is the same. We follow hierarchy of controls. You need to eliminate hazards or eliminate the employee out of a hazardous situation. You can either eliminate the hazard itself or the employee. It's still elimination. You need to, then an example would be chemicals in this case, and noise sometimes. Substitution is also important. Relocate your employees, send them to safer departments from time to time when it's indicated. Engineering controls, make sure that you protect and secure their workplace as much as possible so that it's not hazardous to them. Administrative controls would include your policies, SOPs, the legislation, procedures, training, anything that you can do to make sure you manage that employee's behavior. Personal protective equipment, as you know, colleagues, some pregnant people will be working in radiation exposure areas, and during certain periods of their pregnancy, you may give them lead aprons or PPE as necessitated. Then in terms of complications, you always need to follow a multidisciplinary approach. OMP must be involved, occupational nurse must be involved. Let health and safety know what we are dealing with. If we have emergency situations, we must always be ready to react. Sometimes people start bleeding in the workplace. Sometimes people start, their waters break or go into early labor. These are some of the complications that you need to know of. And very important, you need to make sure that your working space is very private when you are seeing these pregnant people. Remember, some don't want everybody or the whole nation to know that they are pregnant. We do align ourselves with the guideline 23 from the South African Society of Occupational Medicine, which is titled Regulations for Pregnant Employees. And this policy or document outlines every aspect of pregnancy management in the workplace. And finally, the relief, maternity leave, and at the end of the day, we need to facilitate their departure to go and have their baby. Remember, you need to know the legislation. When is the right time for maternity leave? Loosely explained, I could say the law says at least a month before delivery. And you need to consider the mode of delivery. Sometimes they are going to deliver 2 weeks earlier due to complications. So you may need to adjust your maternity leave time. Because if you're going to let them go at 34, 35 weeks, but they are scheduled for a Caesar at 36 weeks, what about those potential complications? And believe it or not, colleagues, not everybody is excited to go. We do have those employees who don't want to go for either financial reasons or social reasons, husband not giving them attention, and they will rather be at work. Remember, the risk increases with the increasing duration of the pregnancy, and do not cave in and create an unnecessary risk for the clinic or for the employer. If it's time to go, it's time to go. Early and late maternity leave, as I've explained, you may consider early maternity leave during certain complications. Late maternity leave under extremely important circumstances or unavoidable circumstances. Say the patient has the letter from her gynae saying that they can still work 1 more week. I've seen that in the practice. So it's not always as easy as we say it is. And the role of the treating healthcare worker, you need to know who it is and the role that they are playing in this patient's life. Is it somebody that she just goes to whenever she wants to see whether the baby is the boy or a girl? Or is it your regular gynae or GP or local clinic that is managing her actively? You need to know who that is. And there's another issue, leaving small babies at home. People will say, I don't want to leave too early because when I come back, my baby will be too small. If the law says it's time to go, colleagues, please remember it's time to go. All right. Thank you, colleagues. That concludes our introduction. In our next session, we welcome Dr. Mwengezi Sikana. I'm sorry about that autocorrect. Dr. Sikana is a male person who identifies as a male. He has MBCHB from University of the Free State, Master of Medicine in Obs and Gynae from Wits University, and the Fellowship of the College of Obstetricians and Gynecologists from College of Medicines in South Africa. He's currently a specialist obstetrician and gynecology in private practice, specifically Netcare Garden City and Charlotte Maxeke Academic Hospital. He is also a lecturer at Wits University, obviously teaching obstetrics and gynecology. Dr. Sikana, are you there?
Yes, I am.
Okay, Doc. Thank you very much. We welcome you. Let's see if you can share your slides from your side.
Okay.
I'm going to stop sharing. Stop share.
Okay.
Okay.
Um, so and then from here, where do I go? Share.
Okay, look down. There's a green button saying you. I think you are there, Doc.
Okay.
Yes. Please go into the full screen mode. Thank you, Doc. Please go ahead.
Okay, can you see the slides?
Yes,
All
Doc.
right. Good evening. Okay, good evening, everyone. My name is Mungezi Stana, and thank you, Dr. Mkwanazi, for inviting me. I don't have a lot of slides, but I think we can go for it. Yeah, so I've been asked to present on managing pregnant employees. So, I mean, the outline of my talk is going to go through simply so like anatomy and the physiology of pregnancy, physiological changes in pregnancy, antenatal care for working moms, physical limitations of pregnant women in the workplace. We'll touch on the emotional and spiritual aspects, and managing pregnancy-related emergencies at work, and lactation at work. Yeah. So, in terms of the anatomy and physiology of pregnancy, easily put, I didn't want to complicate things. So I think it starts with fertilization by the sperm fertilizing the ovum, then implantation of the zygote into the uterus. Then, the placenta forms the umbilical cord, bringing nutrients and blood to the fetus as it develops. You would have the amniotic sac and the fluid that protects the pregnancy really and regulates the temperature in the uterus. Then simultaneously with that, we've got fetal development. The hormonal support really comes from the placenta to support the pregnancy. And then finally, the baby is delivered. So I think simply put, this is what we would look at. And then there are physiological changes in pregnancy. So I think these few that I've mentioned here are very important. So from a cardiovascular system point of view, the cardiac output increases. Most patients, when they're pregnant, will have an increased heart rate, but usually their BPs should decrease. And then when we look at the respiratory system, you will find that there is changes in the tidal volume. Patients really don't have increased respiratory breathing, but they breathe a little bit deeper. And then in terms of the renal system, there is increased blood supply to the kidneys. And most of the time, pregnant women have urinary frequency. So it's normal if that happens in pregnancy. In terms of the gastrointestinal system, pregnant women are prone to constipation, and the cause of that usually is the progesterone hormone, the supplements that they take. So that's why we encourage patients to take at least a minimum of 2 liters of water per day, to eat, green fruits and vegetables, and to eat prunes and maybe take cranberry juice. So, and pregnant women are also prone to nausea and vomiting. So these are the normal physiological changes in pregnancy. So, and then lastly, touching on the musculoskeletal system, these patients are prone to lumbar lordosis. It means that they need to carry, the pregnancy. So their back most of the time is not that straight, and then they most of the time they complain of back pain and ankle swelling. So for the ankle swelling, most of the time it's bilateral. It's not only on one side. All right, so now moving to antenatal care of pregnant mothers. So the important thing is to book early. So an early, ideally less than 12 weeks. And the pregnant mother, excuse me, should inform their health uh, care worker about their work environment and assist with things like workplace adjustment. Like, for instance, if a pregnant mom works at like EMS, loading patients and offloading them, so that wouldn't be good in some instances. So in those cases, we would suggest that, and these patients, pregnant moms should get more breaks at work if possible, and they shouldn't be standing for long at work, and there should be easy and safe access to restrooms. And the next thing is nutrition and hydration. So a balanced diet is important. Like I've touched on hydration, at least a minimum of 2 liters of water per day. And then pregnant women in the workplace, like anybody else, should be on prenatal vitamins and stay hydrated. So in terms of travel and to commute, especially in the third trimester, we wouldn't want like pregnant mom to be taking flights that are more than 4 hours because of risk of venous thrombus disease. In terms of commuting, especially late in pregnancy, it would be like necessary in most cases to find someone that transport the pregnant mom in the workplace. And then, like Dr. Mkwanazi has said, it's important to plan maternity leave. Yeah, and then coming closer to the end of my talk, I would like to touch on physical limitations of pregnant women in the workplace. So I think the 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 limitations of pregnant women in the workplace is fatigue and I mean reduced stamina because of the physiological changes that I've mentioned. Mummies are like have limited mobility and balance because the point of gravity changes and they are prone to falls and stuff like that. They complain of back pain because now they are carrying the pregnancy and they complain of joint pain because there's increased weight. Yeah, and then the other thing that we have seen is that pregnant women do complain of shortness of breath, as you would imagine, as the uterus is growing, is pressing on the diaphragm, that causes shortness of breath. And like I said, because of physiological changes, they are prone to dehydration and they are restricted in terms of lifting and carrying because it's dangerous because of increased risk of falling. And then they swell and have circulation issues. So, in terms of spiritual and emotional aspects, like we all know, and I think Dr. Mkwana has touched on that I mean, pregnant, and most of the time they do have mood swings because of the physiological changes that happen in pregnancy. Most of them they have anxiety and they worry. Sometimes they worry if will will they lose their job? Will the pregnancy last until delivery? Depending on patient to patient, some patients have history of losses and miscarriages. So the anxiety can also come from there. So, and it's important also to be aware of the fact that pregnancy is important to moms at work because it sometimes gives them a sense of purpose and fulfillment. So it's important to have a workplace calm and reassure the patient. Call for medical help immediately. Position the patient, I mean, comfortably and maintain privacy and dignity. And then hopefully the patient, depending on what the emergency is, the patient needs to be sent out or contact the medical personnel who's taking care of them, be it a nurse or a specialist. So on the last one, on lactation network, I think it's important to have designated lactation spaces, give pregnant moms at work flexible break times, have safe milk storages where moms can express and keep the milk, and make sure that there's no discrimination network on lactating moms and just give them support and make sure that legally you comply to the laws relating to lactating moms at work. And then just for conclusion, I think supporting pregnant women at work requires empathy, flexibility, and safe accommodations to protect their health and well-being. And I would like to thank you. We've reached the end of my talk, and I'll be happy to take any questions.
Thank you very much, Doc. I think I saw a hand coming up at some point. I'm kindly asking for the colleague to raise the hand again. And in the meantime, I have two questions of my own. From the ops and gynae point of view, Doc, what would you recommend for occupational health practitioners to focus on in terms of hazards? So, what are the types of hazards that you would say, I don't want this patient working in that environment?
Yeah, Dr. Nkosi, sorry, I missed I think my network is not stable. Can you just say that again?
What are the hazards that you would recommend for us occupational health practitioners to look out for when dealing with pregnant women?
Okay, thank you. So I think the first one would be aerosols, like depending on where the patient works. Yeah, so I mean, like anything in the workplace that is like chemicals. So that's the first hazard that you would need to look at. And I think the way to mitigate that is to make sure that, I mean, there's protective clothing or masks of that sort. So that's the first one. And the second thing is to make sure, because pregnant women are prone to falls, the important thing is we need to make sure that there's, I mean, stairs where they work or lifts. Make sure that, I mean, where they walk, I mean, there's no hazards that can trip them so that they fall. In terms of people who are clean,
Doc?
regulate noise at work. And then I think that's the three that really comes to my mind now.
Thank you very much, Doc. We couldn't hear you for, I think, momentarily. So I don't know if you'd like to repeat your answer again and just summarize it.
Yeah, so I think it's the first one is chemicals, so aerosols, because there's some chemicals that are dangerous in pregnancy. So I think getting, I mean, protective clothing or masks with that regard is important. Number two is to make sure that patients at work can walk freely so that they don't trip because they are prone to falling, and make sure that there's stairs and lifts that work. Then I think the other one is, I mean, just limitation of, I mean, sound at work, depending on where the patient is working. That's all I want.
Okay, Doc. Thank you very much. And the second question is, what potential complications could affect babies from their mother's exposures in the workplace? What could happen to the baby? Because we did mention that we are looking after mothers, but to some extent, we are also looking after the babies. So, what do you think could happen to babies if we're not fully protecting the mothers as we should?
Yeah. So I think the common thing would be miscarriages if the mom is exposed to toxins, be, be it what they smell at work, be it a radiation, depending on where it's coming from. So if we have that, the mummies are prone to miscarriages if we are not on the lookout for that. And then the next thing would be preterm labor, would be, I mean, bleeding in pregnancy, especially if
Doc. Yeah, I think let's give you a moment to reposition yourself while I tackle the next two questions. The first one is from Valerie Madi. Is there a declaration form or guide that an organization can adopt for pregnant women to privately declare according to regulations? Thank you very much for the question. I think that as occupational health practitioners in the workplace, we have that opportunity to design these forms. And remember, we play an advisory role to employers as well. So we have the discretion to decide which forms need to be there. Sometimes you get into the clinic and the form does not exist, and it becomes your responsibility to design such a form. And in this day and age, it's very easy to go online and find some of these examples and draw up your own forms. And you can submit them to the employer for authorization assessment to adopt them formally as a policy. So I think the options are endless. I don't think there is one specific form that is supposed to be used, but there is an occupational health manual from the Department of Health that has different forms that can be used in the workplace. I don't have it with me now, but I can't really say for sure whether the pregnancy declaration form is there or not. Most of the forms that we use in the workplaces or clinics, you will find them in that manual. I think it's a 114-page manual on occupational health. I think it says occupational health manual for healthcare workers. I think that's the title of the document. You will find as many forms as you would like there, including your noise forms, audio questionnaires, and the clinical records, examples of clinical records. I hope I've answered you, Sister Delisile. I've noted your question. I'll give you a platform in a moment while we're waiting for Dr. Sitana to rejoin. With regards to the role of OMP, and this is Dr. Bithamini asking, must the OMP do all the full and extensive 6-weekly antenatal visits for employee at occupational health clinic until they go on a maternity leave? If yes, do you now have to fill in the white antenatal book? Doc, my answer is you are responsible for the workplace environment and that employee being in the workplace environment, but it does not make you an antenatal specialist. So the employee still needs to see the antenatal specialist and or antenatal sisters, midwives, and the least you can do is just keep yourself up to date with the maternity health record to make sure that you understand what's going on, and that will enable you to properly perform your risk assessment in terms of that employee. So I don't think we have to replace what they are doing out there. They still see the patients, they still do ultrasounds, but as a habit, I normally see them every time they have been to their visit to try and learn if there isn't anything new that I need to look out for. And from time to time, I've had to put people on early maternity leave. Obviously, you discuss it with the patient, recommend that, you know what, you are carrying triplets and you are 32 weeks pregnant, your legs are swollen. How about we give you an early maternity leave? You go home, you look after your babies. Obviously, the babies will be born early in any case. And then you come back when the babies are alive. You know, as for the abandonment issues, we'll deal with that afterwards, but at least you have babies that are healthy. And I've also had to recommend early maternity leave for a patient that I think she had placenta previa, or yeah. And the prospects of her experiencing complications at work were very high at the time. And through our consultation with her, we made her realize that this child is precious and it's important for you to deliver the child safely. You'll worry about work later. And remember, employees can come back from maternity leave early also if their doctor has declared them fit to do so. I think as early as 6 weeks or so. So I've had to welcome employees back at 6 weeks also because of financial constraints as well. So as for the antenatal book, Dr. Mine, yeah, as a healthcare worker, you can complete your notes in the antenatal book to make sure that the other doctor knows what you have done and what you are doing. I don't think there's anything restricting us, but you also have to write notes in the patient's file at work. And remember, we have to keep these files for 40 years. So if one day there's a lawsuit that you might have done something that complicated the employee's pregnancy, this might be your way out if you had documented proper notes, because suddenly, conveniently, you won't be able to find that book if you're looking for it. And one other thing I want to highlight, in the Free State, and I think pretty much throughout South Africa, there are stickers that are put on these maternity case record books. Normally, I've memorized it this way. If it's a green sticker, you will deliver at a CHC or district hospital. If it's a yellow sticker, you will deliver at a regional hospital. And also, that's an indication that you are dealing with a complicated pregnancy. And if it's a red sticker, you are dealing with an employee that will most likely deliver at a tertiary hospital. So pay attention to those stickers. Make sure you familiarize yourself with that book without replacing the actual caregiver of that patient. Sister Delisile, may I please ask you to ask your question? Are you able to unmute yourself? I see your hand is raised. Okay. No problems. Please just interrupt me whenever you are ready. The next question is from Sister Laurentia Turner. How about noise zones? We can protect the mother, but not the unborn baby. Yes, sister, that is true. But remember, when we do our risk assessment, we always have to make sure that all the hazards are fully taken care of. So you have to analyze the exposure and the severity of exposure and quantify the risk with the likelihood of complications to occur. And if it is your view that this will be a complicated pregnancy because of such exposures, you may remove employees. I do have clients where I know noise is too high and I remove employees from that area as soon as we find out they are pregnant. So it doesn't have to wait for 20 or 21 weeks. And Alice Matole. Colleagues, can you still hear me? Please respond in the chat room. For lactation, do employees use their lunch time, or do you motivate for them to get time? Thank you very much, Alice. This is a very important question because you do have mothers that will bring their milk suction systems to work. And as soon as they do that, obviously they need privacy to be able to do that. And please, whatever we do, we should not let them do that in the toilets. Imagine having your dinner or your lunch or preparing your partner's lunch in the toilet or in the bathroom, as we like to affectionately call them. So it's not a bad thing to have a lactation policy in the workplace. I'll make you an example with the best one I've seen so far. Heineken SA and sorry for calling them out, but it's a good thing. Heineken SA, at one of their breweries, has a maternal room. I think it's a, yeah, maternal room with nice couches, fridge, microwave, all the essentials you need to uh, produce this milk under sterile conditions. And I think a lot of employers can follow suit. So I don't think it's a bad thing. You need to learn to understand your employees. There are companies that have a majority of their employee or workforce are young people, female. With female women's empowerment, we know that there are a lot of companies who will hire you mostly because you are female, but then have a problem when you fall pregnant. But you can't be 28 and not have a child just because your boss or your workplace doesn't like pregnancies. So we need to be very comprehensive, inclusive, and accommodate them. Dr. Zikana, are you back? I think it might be difficult for him to be back. I see we've reached our limit of 100 participants, and thank you, colleagues, for that. So, how do you apply the hierarchy of controls for a pregnant radiographer? Good question, Doc. Simple. Yeah, we'll deal with this in the next week or so. And yeah, I'm looking forward to a question like this. But I'll just answer generically. For any employee, you do your risk assessment. So you'll compile your occupational risk exposure profile during pregnancy. Remember, the risk profile during pregnancy might not necessarily be the same as prior to the pregnancy. So you prepare occupational risk exposure profile for this employee, design a medical surveillance, what you want to check, and also you have to design the exposure controls for this employee. Is she exposed to noise? Is she exposed to radiation? Did you find out on time? Are you able to remove her and send her to the office? That's elimination. You can eliminate her from that situation. You can't take out the X-ray machine, and give her a camera, so you can't substitute the hazard here. But you could send her to a different department, maybe help the CMO with the admin. I see my former CMO is here. And I always say there is not a single company that hires people with two sets of job specs, the normal job spec and the light duty job spec. And we like saying that, we don't have light duty in this company. And we like saying these people are not sick, they're just pregnant. And unfortunately, we are affecting them emotionally. So go through your hierarchy of controls. We'll have a detailed discussion, 3-hour discussion on this next week, Saturday, on the 3rd, and all the way to your engineering controls if you can. And I'll tell you an important fact. A lead apron may be seen as a PPE, but it also becomes an engineering control if you apply the theory of what an engineering control is. Protect exposure between the employee and the workplace or the hazard. Dr. Roger Linda Makani has a question. How would we go about when the HR states that they cannot accommodate the pregnant woman because they don't have light duty? Example, they often request us to declare the pregnant woman temporarily unfit for work, what I always consider unfair. Doc, you are right, it's unfair. You need to, as a healthcare professional, remember you are there as an expert. You need to stand your ground and say, boss, acknowledge that you're also my boss, but let me speak to the line manager, give me the technical spec sheet or, the job spec. Let me see what I can suggest to make sure that the employee remains fruitful to the company. Because there's a very thin line between that and discrimination. At some point, you might start looking at lawsuits for discrimination in the workplace. And remember how unfair it may be to take that woman's sick leave for something that could have been managed in the workplace. Pregnancy is a very long time, and once they deplete their sick leave, what's going to happen? I hope it answers your question, Doc. Is shift work hazardous to a pregnant woman? And this is Dr. Shiva Kumalo. Not necessarily, Doc, and I think it depends on the type of work that the employee is doing. And in early pregnancy, if there are no complications, you may allow the employee to contribute as much as they can, looking at the risk assessment or her risk profile. But at some point, obviously, you're going to have to stop it. You can't let her continue all the way until she's 34 weeks. And Sister Tena says, thank you. And TNT Healthcare says we can. Okay, I suppose you can hear me. And with so many yeses coming after that. And I think the last question that I'm seeing here, can pregnant women work on height, or is there a specific period when they are declared unfit to work on height? Again, and this is iPhone asking, Doc or sister, I hope we have your name because we don't want you to lose your certificate or CPD points. It also depends. In some cases, an employee would be pregnant working at heights and you wouldn't even know, which highlights the importance of doing your medical surveillance properly, because sometimes you might even do a medical and not do a pregnancy test and only realize when the stomach, when the tummy starts showing that this employee is actually pregnant. So there are instances when they have been allowed unknowingly to work at heights, but I would say as soon as you know and you've done your risk assessment profile, you have the discretion to decide what's safe and what's not. And Sister Delisile, are you back? Are you able to unmute? I'm not sure if I left any question out. If I have, please repost in the chat room. It doesn't look like we have any more questions.
Hi, Doc, and hi, everyone.
Yes, sister, we can hear you. Please go ahead.
Okay, so this is 2 or 4 the doctors in the room. I just want to express my frustration being an occupational health nurse in a client's premises, where we have I think a working pregnancy policy. So the employees are encouraged to report as soon as possible because of the hazards in the workplace.
Mm.
And then we'll give them a letter that's specifically, it's so clear what we need from the doctor. I think 7 out of 10 employees that we send out will come back with 2 sentences that says, I know this patient, she's pregnant, and you're lucky if it will say expected date of delivery is this. That's all.
That's correct, sister.
And after taking the time to explain the hazards of why we need this information, and if we send the patient back, it's like then there's confidentiality card sent to us via the patient. So I just want to appeal to the doctors. We need this information so we can advise our clients if the patient needs to be removed from the current or they can continue to until a certain time period. It's really frustrating. So I hope the doctors will assist. Thanks, Doc.
Thank you very much, sister. And I think it's Dr. Mashaba here. Reasonable accommodation of breastfeeding mothers or workers is the responsibility of the employer in line with the code of practice. Production of breast milk is hormonally dependent, therefore breastfeeding cannot be aligned to a lunch break And I would advise on flexible hours to accommodate the pregnant workers. And I totally agree with you, Doc. Yeah, colleagues, on that note, yeah, please take these questions into the YouTube platform once the video has been posted. I see Dr. Sikana is no longer here, and I'm sure there are questions he would have liked to tackle. Thank you for joining us on this fruitful and informative evening. We look forward to our next installment on the 29th of May, when we'll be discussing everything that has to do with food safety in the occupational and environmental settings. And colleagues, thank you and good night.